Hi, my name is Professor Leonard Calabrese from the Cleveland Clinic, and I'm delighted to present the key posters from the final day of the ACR Convergence 2020. I'd like to thank those who have watched our highlights over ACR. For those who haven't, you can catch up on the whole convergence on cytokinesignaling.com or on YouTube at Cytokine Signaling Forum. I'd like to highlight to begin with, a post-hoc analysis of the Select Choice program presented by Dr. Marty Bergman in the Diagnosis, Manifestations, and Outcomes poster session. This is a post-hoc analysis of the Select Choice study that pitted upadacitinib versus abatacept. We've talked about this in previous poster analyses. This analysis evaluated UPA versus ABA with background of conventional synthetic DMARDs on patient-reported outcomes in patients with inadequate response or intolerance to biologic DMARDs. Essentially, at week 12, UPA-treated patients had significant changes from baseline versus ABA in a number of domains, including the patient global assessment, some pain domains, and the HAQ-DI. Significantly more UPA-treated patients reported greater than the minimal significant difference in the HAQ-DI and the SF-36 at week 12 than ABA-treated patients. And the median time to response in the HAQ-DI was significantly shorter for UPA versus ABA, 2 versus 4 weeks. So this is another piece of data on a very important study, comparing this new JAK inhibitor with a stalwart TNF inhibitor, abatacept, showing greater earlier improvements in patient-reported outcomes with the targeted synthetic DMARD. Next poster selected by the CSF is from Professor Kevin Winthrop and his colleagues. This study analyzes the risk of factors for herpes zoster in patients with receiving upadacitinib. I'm privileged to be part of this. So in this study, patients receiving JAK inhibitors, the background is known to everybody. There's a class-related increased risk of herpes zoster. So this evaluated the incidence of zoster in patients getting UPA 15 and 30 relative to active comparators in the Select 3 trials program. So the key results were essentially that these are in terms of numbers per 100 patient years. Usually in zoster epi, we talk about per 1,000 patient years, but this is 3.1 patients with UPA 15, 5.5 with UPA 30 versus 1 with ADA and methotrexate. If we converted that to 1,000, it would be 31, 55, and 10. This is palpably and significantly different. Most zoster cases, however, were monodermatomal and not disseminated. The risk factors in this study were consistent with many other studies showing Asian region genetics as a major risk factor, but also prior history of herpes zoster. I can't emphasize how important this is, because many people think, and many physicians think, well, if you had it once, you're not going to have it again. So in the setting of targeted therapy, it is definitely a risk in addition to age. So herpes zoster events in patients receiving UPA were more common in 30, those that were not using, versus 15, and both higher than the comparators of ADA methotrexate versus methotrexate. The next poster I'd like to look at is the effect of vaccines with JAK inhibitors. And the first is by Dr. Hannah Kalmark and her colleagues. And it focuses on the immunogenicity of the adjuvanted subunit vaccine that we refer to as Shingrix. Well, as we all know, and we've been talking about, zoster is a risk to patients with RA in general, and dramatically increased in patients on JAK inhibitors. So this study wanted to look at some of the basic immunobiology of immunization with the adjuvanted subunit vaccine that we know as Shingrix. So they took baseline samples, and then they assessed a number of weeks after the second vaccine, and they looked at mean change in the anti-VCV glycoprotein E antibody, which is considered key in immunization. And they found that indeed that there was a boost in pre and post vaccination of about 1.8, this is relative value unit for the RA patients versus 2.6 for controls. And the levels considered protective were achieved in 75% of RA patients versus 100% of controls. So be mindful here. There's a palpable decrease, but still a very robust response. And in the follow-up of these patients, no zoster was reported up to 15 months. So preliminary results show satisfactory serologic response and acceptable tolerability of 2 doses of the subunit vaccine in RA treated with a JAK inhibitor. You know, this small decrement in response, will that translate to increased zoster as we follow patients for, 1, 5, 10 years down the road? I don't know. Some recent data has shown that in patients without RA who get the subunit vaccine, that even when they do get zoster, they have lower levels of pain and disability and lower levels of post-herpetic zoster. Will that translate to RA? I'm not sure. Another poster by Kevin Winthrop, who's a very busy guy at this meeting, evaluated the response to pneumococcal vaccines in RA receiving UPA. And this is important because it's been looked at with other JAK inhibitors, and there's been some questions of interactions. So this aimed to assess the long-term impact of UPA 15 or 30 plus methotrexate on immunologic responses to PCV13 in the ongoing phase 2 open label extension called Balance Extend. Now note, methotrexate is part of this package, and methotrexate is known to inhibit antibody responses to both T-cell dependent and T-cell independent antigens. So there's a complication here. But it was found that satisfactory humoral response to PCV13 occurred in 67, 56% of patients at week 4, and in 64 and 54% patients at week 12 in the 15 and 30 milligram respective doses. There were 2 AEs related to UPA reported, but none were serious. So humoral responses to PCV13 receiving long-term treatment with UPA and methotrexate is broadly consistent with that seen in patients treated with other JAK biologics or placebo. And again, the issue of methotrexate and whether we need to be considering holding it in this setting, that's a separate issue, but something that we're very interested in. There was an interesting basic science poster from Dr. Isozaki and colleagues in the cytokines and cell trafficking session. They looked at Filgo-induced inhibition of monocyte pro-inflammatory cytokine population in osteoblasts using a human osteosarcoma line. So this is, again, getting back to examining the effects of JAK inhibitors on the domain of bone health. So this is some heavy stepping for those of us that don't do bone biology. But what they found was that in these ex vivo analyses, first of all, using this cell line, JAK1, 2, and 3 was expressed in osteoblasts in these MG63 cell line. Secondly, they looked at phosphorylated STAT1 and STAT3 signaling in IL-6 and IL-6R, cis and trans stimulated Filgo-treated M63 cells, and it was significantly decreased compared to non-treated cells. Then they looked at some chemokines, MCP1, CCL2, in these cell treat lines, and it was significantly decreased compared with the non-treated medium. And finally, another key chemokine ligand, CXL16, was found in Filgo-treated MG63 conditioned medium, was also significantly decreased when compared to the non-treated control medium. So collectively, to my reading of this, this favors the perspective that filgotinib inhibits pro-inflammatory cytokine production and monocyte differentiation, which is critical in this balance of osteoclastogenesis and osteoblastogenesis. So it indicates that bone metabolism may prevent bone destruction. We've looked at traditional bone markers in a previous highlight from the other day, which showed data consistent with enhancement of bone health. So I want to thank you for tuning into this final edition of the CSF Daily Highlights. Hope it's been informative to you. CSF is providing extensive coverage of ACR Convergence 2020 on the CSF website. Follow this on Twitter. You can find highlights of the whole convergence on our website, cytokinesignaling.com, and on YouTube at Cytokine Signaling Forum. Come back and see us often. Thanks.